So our next speaker is Dr. Jessica Ang, and she is a movement disorder specialist here at Stanford. And she just finished up her movement disorder fellowship at UCSF last year. So we're very glad that we could snag her to come here at Stanford. And one of her interests are in assessing treatment and diagnostic tools for movement disorders like the three that are represented here today. So she'll be talking about what caregivers can do for PSP, MSA, and CBD.
Thank you for the introductions, Robin. So like Robin said, I'm a movement disorder neurologist here at Stanford. I'm also a caregiver for my mom with metastatic cancer. So even though I'm standing behind this podium, I know that there's so much I can learn from all of you. And I have so much respect for what you do. And in my role as a neurologist, so much of what I do hinges on that partnership with caregivers who are there bringing the patients to the appointments, taking notes during the visit, or asking me the hard questions. And my plan wouldn't mean anything if there's not caregivers and helping developing that plan. So I'm really grateful for this opportunity to give this talk. I know we only have under an hour, so I really try to focus that content on what I would find helpful as a caregiver, really putting myself in your shoes. Also, like more common things I hear from caregivers of patients that I take care of. So like I said, because we only have under an hour, we'll do a very brief overview of MSA, PSP, and CBD, including some of the more common terms you might come across from the neurologist, clinical progression, including like symptoms for each of these diagnoses, some of the challenges that come with the diagnosis, making that diagnosis, as well as like a discussion on whether a treatment with carbidopa-levodopa should be tried. And then the bulk of the talk, I really want to focus on motor and non-motor symptoms, and then including symptom-specific treatments that we can offer. This is not a comprehensive list, even though I'm going through quite a few symptoms. Notably, I'm not talking about like cognition, mood, and behavior changes. I just don't feel like we have enough time to give those topics the attention they deserve, but that can definitely, have those symptoms in people with MSA, PSP, and CBD. And then last, at the end, I would offer some tips on how to make the most of the neurology visit, telling you how to prepare for the visit and what is kind of helpful from my perspective as a neurologist to know from the caregivers. All right, so just a disclaimer, this is a reminder that what we're going over is just the tip of the iceberg. Even within each of these diagnoses, there are different subtypes and variants, and even people with the same diagnosis, same subtype, their clinical course can be vastly different. And then again, I'll be going through symptoms that are more for your awareness so that you can be on the lookout for the symptoms, but it doesn't mean that the person you're caring for will develop these symptoms. Okay, so you might have heard the terms Parkinsonism, atypical Parkinsonism, or Parkinson's plus, and sometimes us as providers tend to throw out these jargons out that can be confusing. So I thought that we would start with definition, make sure we're all on the same page. So just briefly, like MSA, multiple system atrophy, PSP, progressive supranuclear palsy, CBD, cortical basal degeneration, they're all categorized under this group of progressive neurodegenerative disorders called atypical Parkinsonism or Parkinson's plus. And then Parkinsonism really just refers to what we're seeing on exam. And then under that umbrella, so when we see these kind of exam findings that we're calling Parkinsonism, under that umbrella is different types of causes for Parkinsonism, being Parkinson's disease being more common, as well as atypical Parkinsonism, and then other secondary causes like medications that can cause side effects that manifest as Parkinsonism, but they don't have Parkinson's disease or atypical Parkinsonism. And then under the umbrella of atypical Parkinsonism, that's where we kind of subdivide into MSA, PSP, and CBD. And then Parkinsonism, like I said, it's exam findings. What I'm looking for on exam is like this slowness of movements, this particular slowness of movements that we call bradykinesia. And you can see here, it's not just slow, but actually a change in the amplitude and the speed with repetitive movements. So you might see kind of your loved ones going through their neurology exam, and they're going to have them do finger taps, like hands opening and closing. And what I'm looking for is like the movements will get slower and then smaller with kind of repetitions. And then you have to have bradykinesia and rigidity or rest tremors for it to be considered Parkinsonism. And that's just kind of what rest tremors looks like. It's a slow, like 4 to 6 hertz. Sometimes we call it a rolling tremors, what can have this like rolling quality to it. And it's usually there when they're not paying attention to it, when their limb is fully at rest. All right. Okay. Atypical Parkinsonism can present very similarly as Parkinson's at the initial presentation with some of the motor symptoms that we talked about, the bradykinesia, rest tremors, rigidity, but they usually have more advanced symptoms within 1 to 3 years. MSA in particular, they can have more of autonomic nervous system involvements. So like incontinence, losing control of urine, fainting from low blood pressure, dizziness and things, as well as affecting their balance and coordination. And then PSP, these are generalizations. So, but just generally what we expect to see is like eye movement problem, especially with difficulty looking down, and then early falls as well. And then in cortical basal syndrome, we can see asymmetric, meaning that one side is more pronounced than other. Apraxia, which refers to an inability to perform a task or execute, a movement, even though there is enough strength, dexterity, or they're able to comprehend, but it's just the execution is impaired. There are these muscle jerks that we can see that we call myoclonus. Sometimes people like throw things up or drop things because of the myoclonus. And then we also see like posturing, usually affecting one side of the body, that we call dystonia. There might or might not be this alien limb phenomenon where the arms and legs will perform a movement on its own, like things like, reaching or grasping involuntarily, that even though it seems like there is a purpose, but it's not intended by the person. There can be times when they have actually difficulty recognizing their own limb as their own. So typically it does progress faster with any of these atypical Parkinsonism compared to Parkinson's disease. The diagnosis of atypical Parkinsonism is challenging and often delayed. A lot of patients are diagnosed initially as Parkinson's disease, and part of the challenge is that clinical exam and history is still our gold standard, and there is not a definitive test. Right. So for instance, there might be some tests that we would consider, including the dopamine transporter scan, or call it DAT scan, where it's a scan done with a tracer binding to the dopamine transporters. And that shows that there is a loss of dopamine neurons in the brain, but that can be abnormal in both people with Parkinson's disease and atypical Parkinsonism. So it really doesn't help us there. There is also a skin biopsy that you might have heard of, and it's looking for alpha-synuclein. So it's a protein aggregate that's abnormal, but we can see that being positive in people with MSA and PD, and more rarely in PSP and CBD. It can still be helpful in cases. So like, for instance, if I'm considering someone, it could be Parkinson's, could be PSP, and if the skin biopsy is negative, then it more strongly suggests PSP for me. So it still has utility, but not definitive. And then there's, in terms of lumbar puncture, where we kind of collect cerebrospinal fluid, there's no specific markers for MSA, PSP, or CBD. There are other testing that could be done. Again, it's not used for the diagnosis, but if we do see certain findings on MRI brain, for instance, that we could see in people with MSA, PSP, or CBD, it could be helpful. But then also, if we don't see these findings, it also doesn't rule out the diagnosis. But you might hear neurologists suggesting kind of getting MRI brain or some of these other tests. So this is just kind of a picture of the dopamine scan. So the bottom is a normal scan where you can see this nice comma shape where the tracers are binding to the dopamine transporters, versus in an abnormal scan where you kind of see that loose of that tail of the comma. And then there is kind of a little bit of asymmetry where one side is a bit more affected than the other. So again, this scan would be, the abnormal scan can be Parkinson's, can be atypical Parkinsonism. So even when a neurologist suspects that they could be seeing an atypical Parkinsonism or a type of it, you might hear them mention a carbidopa, levodopa, or like a Cinemet trial, and which, in my opinion, is worth a discussion with the neurologist. And there are patients of mine who have atypical Parkinsonism on carbidopa, levodopa. There are also patients that I've seen who are started on carbidopa, levodopa, and I've taken them off because of side effects. So I just want you to be aware of like what this medication is used for, what we would think about starting because we want to improve certain symptoms, and then what side effects to look out for. So first of all, carbidopa, levodopa, the other name for it is Cinemet, is a medication that is used more commonly in Parkinson's disease as a symptomatic treatment. And primarily, I'm looking to see if there will be improvement in tremors, stiffness, and clumsiness in movements that we call bradykinesia that we went over earlier. So if the tremor, stiffness, or the bradykinesia are bothersome, then we would consider trying, carbidopa, levodopa to see if that would help. Usually in atypical Parkinsonism compared to Parkinson's disease, the symptoms don't improve as much, or if they improve, they can be short-lived, or there is no improvement at all compared to people with Parkinson's. And then, I am still in the camp that if I think that the symptoms can potentially improve, it's worth trying. But there are some important considerations to think about, right? So for instance, the most common thing I hear from people on Cinemet is there could be nausea, usually going up on the dose slowly over time, or there are other medications we can add on. We'll talk about that in a little bit that can help with mitigating the nausea. The thing that concerns me usually is more with the lightheadedness or dizziness, just because of the blood pressure lowering from Cinemet, especially for people already have autonomic symptoms, or already have low blood pressure to begin with. It can be dangerous. And then for people with like hallucinations, it can worsen hallucinations, or it can even cause new hallucinations. And then the other one that I also think about is like it can cause these involuntary wriggling movements that we call dyskinesia, and that's can be a side effect of the medication too. So those are all things to think about, to talk about with your neurologist if you think that your loved ones can benefit from a trial. All right, so I'm going to shift my focus on talking about motor and non-motor symptoms. So I want to start with walking and balance because this is the most common reason I see people with atypical Parkinsonism and Parkinson's disease end up in the hospital. When it comes to walking and balance, there are several kind of factors and things that can be affected. So the first thing first is the Parkinsonian gait, right? So it refers to kind of a slow shuffling walking, hunch over, and then reduce kind of arm swing. And then there is postural instability, which is kind of this tendency to fall backwards. And it's more common in people with MSA and PSP. And it can even include like spontaneously falling. The other part of it is freezing of gait. The freezing of gait, which is commonly described to me as a sensation that their feet feel stuck to the floor, like it's almost glued to the floor. It can usually more often see it in when they first start walking, with turning, or with like kind of going through like doorway or narrow hallways. And usually along with the freezing of gait, sometimes we can see festination, which is people kind of taking smaller and faster steps, and then with like difficulty kind of stopping themselves and falling that way. So any of these can increase the risk of falling. And thinking about like treatments for it, the mainstay of treatment and what we really rely on is physical therapy and balance and exercise training. I want to use this opportunity to let you guys know that there is like a great resource from Stanford. There's the Stanford Neuroscience Wellness classes that are available to anyone. They actually provide like live stream online classes that is free for anyone to register. They have classes that range from like chair yoga, Tai Chi, or even mindful meditations. It's good for people who might not have access to physical therapy near them, or maybe if you want something extra in between sessions, it's a good resource to take a look at. And then when it comes to freezing of gait that we talked about earlier, some things that we could utilize is like visual or musical cue. So like you can see in the left hand bottom corner there that there is a cane projecting a line. So it's a laser cane. And some people find that, crossing over that line is a little bit easier than kind of initiating the steps. So that's something that we could utilize for people who have significant freezing. Other things that are often can be used as well, like assisted devices, like cane, walker, for people who are really falling often. For head protections, I have recommended, potentially using a helmet as well. Another thing that's often overlooked is getting a home safety evaluation. So that is usually done by occupational therapist, and that can be ordered by either a neurologist or a primary care doctor. So there are some medications that we use particularly for freezing as well, including donepezil, rivastigmine. Those are acetylcholinesterase inhibitors. Rivastigmine comes in a patch as well, so that might be an option for people who have difficulty swallowing pills. And then amantadine is another class of medication that we can use for freezing. It can cause like some sleepiness for some people. It can cause like swelling in the legs. For the purpose of this talk, I probably won't go over too much side effects. I'll just point out the important things. But those are just here for your reference if you want to talk about this with the neurologist. All right. Yeah. Okay. All right, so the next thing I want to talk about is dystonia. So you might have heard this word thrown around as well. It basically refers to involuntary muscle spasms or muscle contractions that leads to posturing of the body. So in this top left corner, picture A here, this is a woman with kind of a lot of facial dystonia with that like kind of activation of some of the frowning, as well as like tilting forward of the head with activations of the muscles in the front of the neck. So that's something that we can see. And then in the picture B, that's like someone with kind of in their left hand, they have bending down of their third to fifth digit, and then actually bending upwards of the second digit on the left hand. In picture C, that's someone with cortical basal syndrome or cortical basal degeneration, and you can see that on kind of one side of the body on the right side, where she has more kind of wrists like bending upwards, but finger bending down, and then a little bit of like kind of hip bending upwards too. So that's kind of affecting more one side versus the other. The other one at the bottom, picture D here, that's someone when they're walking, they kind of have activations of muscles on one side of the spine, causing that kind of curvature there. That can also increase the risk of falling. And then in picture E, that's someone with like kind of their neck bending backwards, what we call retrocollis, and that's more commonly seen in people with PSP. Here, the last picture is a little bit more subtle, but what they're showing here is that on the left hand, there's actually a little bit of finger curling that's happening there. So thinking about treatment options for dystonia, give me one second. Okay. Usually my first go-to is botulinum toxin injections. Part of it is because there's no systemic side effects. It only affects the muscles that we inject. What botulinum toxin does is it relaxes the muscle. So that can help with kind of the dystonia, which is causing too much of the involuntary actions. The only downside of it is it does wears off after 3 months, so it will require kind of more frequent visits with a neurologist. There are different places that we would inject. So what you're seeing here on the bottom of the foot, that's usually what we do for people with toe curling down. So it's one shot in the bottom of the foot, usually does help with relaxing the toes. You see that machine with the stickers here, that's an EMG or electromyography. We do utilize that to kind of let me know that I'm in the right muscle. So when I inject, I can kind of have the muscles activated so that I can hear the sounds of the muscle firing and help me kind of with making sure that I get the toxin in the right muscles. For that patient that we saw earlier, where they have more of that head tilting forward, we can inject a muscle in the neck that relaxes it. With that, there is some issues with kind of swallowing issues too, especially with that muscle. So that's something to kind of keep in mind. And then in certain people, especially with more facial involvement, they can have, like for instance, like eye closing. So kind of the muscles around the eyes being too activated, that it's forcing their eyes to close and affecting them in terms of balance, eating, things like that. So we can do injections around the eye muscles too. There are medications that we can use too. including muscle relaxants like baclofen or other medications like, clonazepam, which is a long-acting benzodiazepine, or triacylphenidol. That tends not to be my go-to. I try to do as much as I can with Botox, especially if there are muscles that I can inject, just because of the side effects. Like, it can cause a lot of sleepiness with these medications, some confusion and disorientation, which is already a problem with people in MSA, CBD, and PSP. So I try not to exacerbate that. All right. Okay, so thinking about bulbar symptoms. So again, these are terms that you might hear from your neurologist. So there is dysarthria, which is kind of trouble with articulation of speech; dysphagia, trouble with coordinated swallowing; sialorrhea refers to drooling of the saliva. And the drooling is actually not from too much production of saliva. People are actually producing the same amount of saliva, but it's more that there is less swallowing involved. So that's what's causing the drooling. And then there is more specific to MSA, something called stridor, which is a really high pitched sound, usually with inspiration. And that can actually cause some respiratory crisis. So I want to make sure that we can hear a video of it so you can see what it sounds like. So this can happen during sleep, but it can also happen during the day too. If you hear that and kind of the person you're caring for, it does require a lot of times there's so much going on that you might not mention it to your neurologist, but as a neurologist, I really want to know about it if you do hear these noisy high-pitched breathing. So, sorry. Okay. All right. So treatments, you will see that my treatment approach tends to be, I consider myself more as a minimalist, and I do think that I hope that your providers are also the same, where you think about what we can do without medication. So like non-pharmacological, like the treatments first, as well as, thinking about other things that I can take away instead of adding something new. And then I always start with like the thing with the least side effects first. So that's kind of my approach in thinking about how to manage the symptoms. So for dysarthria, dysphagia, really like getting speech therapy involved as early as possible, and then getting a swallowing study done. And then based on the results of that, we can think about, how we can change up the diet. And then for drooling, we can actually do Botox injections as well, where we can inject the salivary gland, so the gland that produces saliva. There are also medications like drops, atropine drops that we can use, or like a pill form called glycopyrrolate that we can use. Before all of this, and I didn't put it in here, is like even just like chewing on candy sometimes is helpful too, just because it stimulates that swallowing, right, that we talked about. And then stridor, if that happens, it really is kind of an emergency that I usually would refer to ear, nose, and throat for consideration of a tracheostomy, and that at times can be life-saving. All right. Okay. So thinking about sleep, which is something I hear a lot, there is kind of different components to it, starting with insomnia, which could be difficulty falling asleep, as well as difficulty staying asleep. And there are multiple reasons for that. Some things that, to think about is that like motor symptoms like stiffness, maybe pain from dystonia, making it hard to sleep. Is it needing to go to urinate like often, right? Causing it like kind of interruptions in sleep that way, or anxiety, ruminations, like making it hard to fall asleep or fall back asleep. There is also this phenomenon called REM sleep behavior disorders, which we see more commonly in people with Parkinson's and MSA, where they can have these really vivid dreams, but also acting out their dreams. So you can see here, this is kind of someone doing a sleep study where they're moving around a lot, and can get pretty violent. Like she's punching and kind of moving around a lot. I definitely have, people who have hurt themselves quite seriously from falling and hitting their head and having a brain bleed that way, or have kind of shatter a mirror and have broken glass all over their back. So if this happens, like I want to know about it, and there are ways that we can manage it. And then another part is like, sleepiness during the day, which can be quite profound as well, and really affects quality of life. So thinking about treatments for insomnia, usually again, starting with sleep hygiene, like non-pharmaceutical, starting with like cognitive behavioral therapy that we might be able to kind of help with falling asleep. And then, making sure that we get a sleep study done as well to rule out other causes like obstructive sleep apnea or like limb movements that are keeping them awake. And then lastly, we consider, other medications like melatonin that we can use, trazodone or mirtazapine. And that would be more specific to, depending on what we're trying to target. And then for REM sleep behavior disorder, first thing first is always bed safety, right? Making sure that the bed is low, there is something soft for them to, fall if they fall out of bed, and then making sure we're removing anything else that they can grasp and like hurt themselves that way. Bed rails can be helpful. Removing the bed partner, just because the bed partner can also be injured because of these acting out dreams behaviors. There are medications that we try. Even though clonazepam has a little bit better evidence for REM sleep behavior disorder, I tend to start with melatonin just because it has less side effects. It will be a higher dose than what we would normally see over the counter. Over the counter might be 1 to 2 milligrams, but I usually start with at least 3 milligrams and we'll go as high up as 12 or even 15 milligrams. And then for treatment of like daytime sleepiness, usually I would think about what medications are on. Like I said, there are many medications that can cause sleepiness. If someone is on Sinemet or levodopa or even a dopamine agonist, and it's not giving too much motor benefit, sometimes I think about peeling that off, and that might help them with the sleepiness. Adding caffeine can also be helpful. So like if someone is a coffee or tea drinker, maybe just adding that extra boost of caffeine in the afternoon can be helpful. And the last thing is like, light therapy, which light is kind of a main circadian driver. So like half an hour a day of light therapy, or even just on a sunny day like today, getting them outside and in the afternoon would be great. Okay. So I'm going to talk about autonomic nervous system. I'm not going to go into details about this, but essentially this is a nervous system that we don't have to think about, right? So the system that helps you with the breathing, the digestion, sweating, and things like that. So thinking about, I just want to make sure I have a little bit longer time, right? Because I'm getting a warning for, I probably have 15 minutes. Yeah, I got a warning for 1 minute. I just want to make sure. Okay. Yeah. Okay, I have probably around 15 minutes more. Yeah, sorry about that. Okay, so in terms of blood pressure issues, you might hear the terms orthostatic hypotension. What we're referring to is a drop in the systolic blood pressure. So the higher number of 20 points or the lower number diastolic blood pressure of 10 points when the person stand up. And this can be delayed. It can be delayed up to 5 minutes, even 10 minutes. And the symptoms that I hear more commonly, if they get lightheaded or dizzy, especially with changing positions, from lying down to sitting or from sitting to standing or from standing for a long time. There are other symptoms, even without lightheadedness or dizziness, that can present. Things like what we call coat hanger pain, so that shoulder and neck pain that happens with positional change. Fatigue can also be from low blood pressure, or blurred vision can be from low blood pressure. It can cause syncope, so it can cause fainting, and if someone's faint, it can also cause dizziness, it cause falls. So I do think that should be something that we should know as a neurologist and something to monitor for. In terms of treatment, so first thing first, again, ruling out other causes, right? Is it really a blood pressure issue? And then if it's a blood pressure issue, are they on blood pressure medications, right? So like other things that, or even like things like urinary, like urgency or like frequency. Sometimes people are on like Flomax, for instance. It can also lower your blood pressure. So there are medications that I would take a look at to see if there are other causes first. Making sure I don't miss any cardiac causes, right? Is there like, a heart issue that's causing, the dizziness or lightheadedness or the fainting episode? And then in terms of like non-pharmacological measures, which is what I usually start with. So I, cannot emphasize enough, like the importance of hydration. People always ask me how much water I should be drinking. I usually recommend half their body weight in pounds is how many ounces of water they should be drinking. So if you're 120 pounds, at least 60 ounces of water in a day. Addition of salt is also helpful. Sometimes I have people kind of do a salty snack, like maybe mid-morning or afternoon, like nuts and whatnot, just to bring up that salt level so you can help retain that fluid. Avoiding big meals, which sounds a little silly, but I can't tell you how many times I've heard that story where people have a big meal, they stand up and then they pass out. Because having a big meal can also lower your blood pressure. So if you already have orthostatic hypotension, the two together is just not a good combination. Raising the head of bed can also be helpful. If they have a hospital bed, like raising it to 30 degrees can be helpful. If they don't have that, like having that wedge pillow can also be helpful, but like, doubling in terms of like 2 or 3 pillows usually is not as good. Abdominal binder and compression socks can also be helpful. Abdominal binder, just remember that you have to put it on when you're in bed and then stand up. So don't put it on standing up. And then compression socks, I normally recommend thigh high is the best studied for, but as much as possible. Medications, there are a whole host of medications, things to think about like midodrine, fludrocortisol, pyridostigmine, droxidopa. They can cause what we call supine hypertension. So it can raise actually blood pressure when they're lying down. Okay. All right, constipation, that's also a big one. So constipation can be heart stool, small volume stool without straining. It can cause bloating, it can cause nausea, it can cause, people have loss of appetite, and it can alternate actually between constipation and diarrhea. And I hear that a lot where people are like, I don't want to take stool softeners because I have diarrhea, but I also have constipation. But the reason for the diarrhea is actually what we call overflow diarrhea, where it's actually a result of the constipation. So it still would be managed with kind of the same way as constipation. It can be quite serious. It can lead to malnutrition. It can lead to weight loss, and it can really impact people's quality of life, right? So again, hydration, we talked about. High fiber diet. High fiber diet only works if you're also making sure you're drinking enough. Prune juice can be really helpful, like a glass of warm prune juice in the morning. Probiotics can be helpful too. I usually, depending on the description of the constipation, I would think about, like senna, which is kind of a stimulant with promoting like gut motility, and then Miralax, which is softening the stool, and maybe a combination of the two. And if someone is on carbidopa, levodopa, and they're having nausea as a side effect, sometimes we add on additional carbidopa so they tolerate it a little bit better. Okay. And then in terms of urination issues, it can present differently. One is kind of overactive or bladder, where it presents as this urgency, like it's hard to hold the urine when you have to go, or even not making it to the bathroom. Or it can present as retention, which is kind of difficulty with bladder emptying, where even after you go, you feel like there's still kind of urine left over. And it can present with like needing to go to bathroom more frequently. It can present with this like urgency, and then it can present with like kind of leaking, like not making it to the bathroom, or even incontinence, or like a lot of getting up in the middle of the night to urinate. So first thing first, again, I especially in men with like other comorbidities, like I think about asking a urologist to help to see if there are other structural causes that we need to take care of first. And then in terms of medications, my go-to are usually trospium or mirabegron. There are other medications like oxybutynin and things. I try to avoid those just because of the cognitive side effects. There are other non-pharmacological options too. I think usually in this case, we start with the medications that I talk about, the least offending one, and then we would think about like maybe stepping up to bladder Botox injections or stimulations or even catheterization. But usually those are managed by urology. Okay, so that's kind of the end. I just wanted to spend the next probably 10 minutes talking about how to make the most of the neurology visits. I think caregivers are often involved in kind of a lot of these visits, so it's good to kind of think about what you can do. Before the visit, I would say kind of keep a list of symptoms or questions that are easily accessible that you can review before the visit. So for me, I usually keep, like when the symptoms come up or questions come up, I try to keep a list on my phone that I can always add to. And then before the visit, I kind of take a look at that list and think about what should be on the top in terms of things I definitely want to go over, things that if I have time, then, or like kind of other questions kind of saving at the bottom. And then thinking about reviewing and make sure the medication lists are updated, including the name of the medication, the dose of the medication, the timing of the medication. The other thing I would encourage you to do is like before the visit, talk to the person you're caring for, like what your role is as a caregiver, right? And it's helpful to make sure that also aligns with the desire of the patients. So it's important to have that discussion with the patient as well as the healthcare providers when you're seeing them. So whether that means like you would have access to their healthcare portal, whether that means like there should be documentation on whether the caregiver can talk to the healthcare providers about their care, whether there should be formal healthcare power of attorney documentation as needed as well. And then if there is an interest in a clinical trial, I really encourage you to kind of look into clinicaltrial.gov. There are actually different filters you can apply to see like what is open, what is enrolling, like because as a movement disorder neurologist, I'm seeing atypical Parkinsonism, but also other movement disorder like as well. So I might not be as up to date as like, you as a caregiver with that particular diagnosis that you can see and ask me about when you do see your neurologist, whether you would be eligible for that trial and whatnot. Okay, and then during the visit, I really encourage you to bring up the most bothersome concern first, because again, I can't tell you how many times I've seen a patient where we spent, the first 25 minutes talking about the medications, and then the last 5 minutes is when they were like, oh, actually, like I'm really concerned about my constipation, and then we have like 5 minutes to talk about that. So bring up the most bothersome thing in the beginning, bring up any safety concerns that if your neurologist is not asking you, like, mention it. Like any balance issue, any falls issue, any swallowing difficulties. Like I said, those are things that medication doesn't help as much with. So I really want to know about it early so I can, set you up with, our speech therapist, our physical therapist to make sure we get ahead of it before the falls happen, before the aspiration happens. Any presence of dangers in the house, so things like firearms or like unsafe stairs, or like, loose rugs, anything like that, I want to know about. Any unsafe practice that you might notice. Things like leaving the stove on, things like being really impulsive and getting out even though they're not safe to do so, or like if they're unsafe driving behind the wheel that you're concerned about. These issues, like I usually ask about it, but a lot of times like I'm not there with the person as much as you guys are. So I really rely on the caregiver feedback and helping me with that. And then other things to think about is like asking for what to watch out for, right? So some of these went over already, but like, everyone's case is different, like we said in the beginning. So like asking the neurologist, like what exactly should I be watching out for? What should I expect, right? In terms of like before our next visit. And then wrapping up, thinking about, how make sure you have a way of contacting your doctor or their support staff with follow-up questions or updates before the next visit. And then a way to access the note or the assessment so you can share with other people, like the primary care doctor, the urologist, other kind of providers who are involved. All right, just quick last note here. I know Dr. Larson already covered a lot of this, but being a caregiver and a care partner is really hard. It can be exhausting, can be frustrating at times, and you're not alone. As a caregiver, I think a lot of times we're really close to the patient and they can suffer the diagnosis silently. So caring for the patient, sometimes it can come with feelings of resentment, regret, anxiety, depression, fatigue, isolation, or even guilt. Those are all very common things. And I really encourage you to take care of yourself, right? Make sure you're bringing these things up to your, healthcare providers so that they know that you're struggling if you need help. Reach out to any resources. I'm not going to belabor this because I know that we have talked about this already. Okay, and these are my references, and then that's my last slide. Okay.
Okay, great. Thank you so much, Dr. Wonderful. We've got a lot of questions, and again, people in the room, if you have questions, write it down on a card, and Denise and other volunteers will come around. I see Jocelyn moving and Candy as well. So we've got a lot of Zoom questions already. First one, I'll try to get to some general ones first and then some disease specific ones. So do you have any tips to how to help our loved ones with postural instability or gait festination outside of physical therapy?
Yeah, I think working with the right type of physical therapist is important. So like someone who's familiar with working with people with Parkinsonism, because a lot of, like I said, like there are these additional like cueing, like musical cueing that they can utilize, things like taking a wider turn. But these are all tips and tricks that like if it's a physical therapist who know how to work with people with Parkinsonism is helpful. There are certain type of walkers that might be a little bit better. So like those something that, when you go to the physical therapy appointment, make sure you're bringing the assistive devices that they're using at home with you so they can see how you're using it. Because so many times I see patients come with a cane and they're holding the cane in air, right? So that's not really helping. Or they come with a cane that has, that one point. So even when they fall, it's not really giving them any stability. So bringing the assistive device to them, and then they can also, take a look at it and then see if they have other assistive devices that they might try, right? So for instance, someone with like really hunch over, they're looking at the floor, they're falling forward because of the hunch over posture, like maybe a higher walker would be helpful in helping them keeping more upright, right? So something like that they could try and utilize in the physical therapy. But I wouldn't kind of sign off and think that physical therapy is not helpful. I would just say like make sure you're using it the right way.
Okay.
Yeah.
And I appreciate it if you can be brief with your answers so we
I
can
will
get
try.
through a lot. Yeah, thank you so much.
Don't want to say.
I
Yes.
know. Okay. Any ideas how to support someone to do their exercises when they experience apathy?
Yeah, that's really challenging. I struggle with that myself as well. So I think starting with small goals, right? Like you don't have to commit to an hour of exercising or like 3 hours per week. Like starting with like 10 minutes, right? Starting with 10 minutes, maybe multiple times a day, right? Like goals that seems feasible and achievable, right? And it doesn't have to be like we have to go hit the gym or like we have to go, take this class. It can be as small as let's go outside for a walk, right? For 10 minutes. And then we can do that maybe before lunch and we can do one after dinner, something like that, right? And then adding something a little bit more every day. So it feels like you can see, even doing the same walks, like seeing kind of your progress is also going to be helpful too. So I'll keep it brief. Yeah.
Okay, thank you. What can be done for dysphagia and trying to keep somebody hydrated?
Yeah, so if they haven't had a swallowing study or if they haven't seen a speech therapist first, I would start with that. Just because there are times when we have to thicken liquids to prevent risk of aspirations. So again, same thing. If hydration is important, and there's so much that goes into it in terms of apathy or even just like trouble swallowing. But if it's primarily a trouble with swallowing, then working with a speech therapist to see how we can get that hydration in safely.
Okay, kind of related to that, someone says that their family member decided to get a G tube inserted a year and a half ago. What can I expect to end her life?
That's a difficult question to answer. I think that if a G tube is placed, it's to minimize that risk of aspiration. Someone probably thought that they're at high risk for aspiration. Um, you know, there's so many things that can happen. It depends on the condition. I think it's really difficult to answer that question.
Okay, that's fine.
Yeah.
Let's go on to the next one. How can you tell the difference between stridor and snoring? They sounded the same to me. Maybe have stridor.
Yeah, if you have questions, something that's really helpful is just record it, right? Like how I show you the audio clip or the video, just as a caregiver, like record what you're hearing and show your neurologist, right? That's one way of, and if they have further questions, we can always do a sleep study.
Okay. If the patient has heart failure and neurogenic orthostatic hypotension, how do you go about balancing limiting fluid intake for heart support, yet staying hydrated enough to support the orthostatic hypotension?
Yeah. So for someone who have like kidney or heart issues where they're on fluid restrictions, then we really utilize some of the other things I talked about, like compression socks or abdominal binder, like the same things, so like raising the head a bit, like those things are still okay. People with heart failure or other conditions as well. So there are other things that we could try. And then some of the medications I mentioned, I usually will have to check with the cardiologist because they can potentially interact with some of the other medications that they're on. So I usually do double check with the cardiologist before starting them on a medication for orthostatic hypotension.
Okay, my family member only has one bowel movement a week. Is that safe? Would taking lactulose daily be safe to prevent this?
Yeah, constipation can probably be another hour lecture on its own. There's so many ways of managing it. I think it depends on like their food intake. It depends on, how much they're struggling, how much it's affecting their quality of life, whether there are other symptoms that are also involved. Lactulose, it's a medication that I do use, and it can be used safely on a regular basis. And it might sometimes require more than just one medication. But the key with kind of bowel regimen is that you have to take it consistently, right? It's not used as needed basis. It has to be every day.
Okay, how often should a person have a swallow study to ensure that information is accurate and up to date?
Yeah, I don't have a set guideline in terms of timeline, in terms of when I would do a swallowing study. Usually for any patient who is seeing me as a new Parkinsonism presentation, especially for atypical Parkinsonism, I do get a swallowing study just as a baseline. And then, if there is kind of concerns that the family has brought up or the patient brought up in terms of new, like, kind of type of dysphagia or swallowing difficulty, then I would redo another evaluation. I don't think there's a set time with like, we have to do it every year or we can't do it more often than a year. It really is depending on the symptoms.
Okay. Is there such a thing as respiratory therapy to help with any of these conditions?
So for what I had talked about with the stridor, sometimes, or for people with sleep apnea, which is also common in people with Parkinsonism, we could use kind of respiratory devices like CPAP, or like BiPAP, for instance. Like, so in that case, we would kind of get our respiratory therapist involved as well. Or if they have stridor, MSA, and have kind of the tracheostomy, then we will also involve the respiratory therapist.
Okay. My family member has corticobasal degeneration, and but I'm wondering if Botox will stop working at some point. I assume they're talking about dystonia.
Yeah.
It doesn't seem to be working quite as well as it used to. Are there any other options?
Yeah. I don't think Botox will stop working. I think that there is kind of that possibility of the disease progression being faster than what Botox can offer relief for. So it's always a discussion with the provider to see if kind of adding on like kind of a higher dose or adding on different muscles. And that's why it's good to see have that appointment every 3 months, right? So we can kind of do a kind of assessment every visit. And then the other thing too to consider is like, is there a possibility of shortening, like maybe doing it every 10 weeks instead of every 12 weeks? That's something that you can discuss with the neurologist too.
Okay. Do you recommend acupuncture for symptomatic treatment?
I don't have enough experience in that to recommend it. I don't think that it contradicts with anything else that we would offer in terms of medication. So I wouldn't advise against it as well, but I don't know how much evidence there is behind it.
Okay. Somebody asks, are there any benefits to a feeding tube? I wonder if I should be having a conversation with my family member about what they want.
Yes, definitely. I think that's something we should all have with our family members, even, with or without a neurodegenerative conditions, like what type of interventions that they would want at kind of if things were to progress. And then if you're thinking about could they benefit from a feeding tube, definitely have that discussion with a neurologist.
Okay. Is there anything to help with alien limb phenomenon?
That's a challenging one. The physical therapy can be helpful. There is not a specific medication that we would use to treat that. And it depends on what that alien limb is doing too.
Okay, this is our last question, and you have single-handedly helped us catch up on a lot of time. So you go, girl. Okay, I love this question too. When a caregiver shares concerns and is obviously distressed, what do you, as the neurologist, do?
Yeah, I encourage again. It's difficult. Like I said, I always see it as a partnership between me and the caregiver, and kind of we're on the same front, right? So I want to make sure that they are also okay, and then that way, like, it's the best, providing the best care for the patient themselves. I think a lot of times I would refer them to kind of support groups like this, right? Like where they can turn to other people that can be connected through other resources, or recommending that they talk to their own like therapists or healthcare providers about this, knowing that normalizing that experience for them as well, that it's common to feel that way, and sharing with them like what resources I know, right? I think Dr. Larson already went over a lot of this as well.
Great. Thank you so much, Dr. Eng. Oh, that's wonderful.
Thank you.
And we always like highlighting support groups.